have been already mentioned, and I'm very happy the discussion already started. I will try to give some different perspective just to keep the discussion going. So here we just start on the wrong foot because we are talking about high-risk patients with deletion 17p. This is somehow an old concept. We know since at least 15 years that patients carrying 17p deletion do have a worse clinical outcome. This is known since 2000, thanks to Dörner and Stegebauer. And this is deletion 17p, I just want to remind once more, can be detected by FISH. While we also learned later on, but it's not moving. The next slide. Next slide. Oops. No. So in the next slide, I will show that. Oops. Okay. That indeed we learned more recently that there are patients who can carry only mutation on the gene P53, that is the gene deleted in the deletion 17p. And so some patients do have only the mutation without the presence of the deletion. There can be patients who carry both of them, so it will be easier. And the patient with only the mutation in the P53 gene, they have a superimposable outcome compared to those who carry the 17p deletion. So this is what we talk, what we define when we talk about P53 disruptions or the P53 aberrations. This can be detected by FISH. This needs gene sequencing, so typically Sanger sequencing. So why is that? Because we know since a long time that, for example, if we treat patients with FCR first line, patients with 17p deletion have a worse, they tend to respond less well, or they tend to relapse earlier. And the same thing happens with FC or FCR. The patients do respond worse if they carry the mutation in the gene, in the P53 gene without the deletion. So these are considered now, and also the regulatory agency understood that they are considered exactly the same type of patient. But still you need two different tests to identify them. And just for those who didn't believe it, also alemtuzumab, which was considered to be the drug of election for patients with 17p deletion, still did not provide any better outcome, any better efficacy. So this patient in first line, even in patient with first line, this is progression-free. Patient with 17p deletion had a progression-free shorter than 1 year. So again, we go back to what Steve mentioned before. This is the frequency of P53 aberration in total, so 17p and P53 mutation. A diagnosis is very, very low. It should not be tested at diagnosis. We have to repeat a lot of time. This is a test that should not be done at diagnosis because, as Wyndham mentioned, some patients, though carrying aberration in the P53 gene, still have a very nice outcome without any problem. So the test should be performed only in patients who are progressing and needing therapy. So in first line, before the first line, around 15% of the patients do have any of these aberrations. If we go and check not the relapsed patient, where probably the frequency would be around here, if we check the patients who are fludarabine refractory, then we get to that number of 40–50%. Which does not mean that all 50% of all relapsed patients would have it. If you look in the Richter syndrome, it's even a little bit higher. So, but then we define high risk as patients with 17p deletion with P53 mutation, but as we already also mentioned before, this is not covering all patients who relapse, and probably cover only a quarter of them. And indeed, a very nice prognostic marker is somehow useless because it's an ex-post marker. So we can define high-risk patient when we treat the patient and the patient does not respond or relapse earlier. So here, if you look here, patients who relapse between 1 and 3 years have a worse prognosis compared to those who relapse after 3 or even 6 years. This is a very nice way of defining, distinguishing high-risk patient, but of course it's too late. I mean, you already treated the patient with the wrong therapy and you didn't know. And among these, of course, not only 10–15% would have 17p deletion or P53 mutation. So we still need to identify ex ante, as we can say, these patients before starting the therapy. And again, so now we are in a better position, as mentioned already by Robin. So we have 2 drugs, at least in Europe, that are approved for first-line treatment in the presence of NTP deletion and p53 mutation. We heard that also in the United States they can be treated as well, but still the problem is that patients are not screened in the first line. And in particular, if they are screened for the 17p deletion by FISH, definitely very rarely are screened for the p53 mutation. That's the reason why the European Research Initiative on CLL, ERIC, started the so-called p53 network. That is really a network of reference labs in each country in Europe that are devoted to spread the knowledge and educate the hematologists to the idea that patients should be screened at the time of progression in need of therapy for the p53 mutation. And if the lab are not able to perform the analysis, then ERIC can also provide help to set up the analysis. So this is something, is a scheme that can be maybe exported also to Latin America. And I think it's very useful because at the end, the number of patients of CLL is not so huge, and patient needing treatment is not also so huge at the end. So it is something that economically is affordable if there is a couple of centers, a couple of laboratories when one can refer the diagnostic sample to have the diagnosis, the test performed. So now we have ibrutinib that gave us some hope because the first follow-up around 18 months of follow-up showed that more or less patients carrying 17p deletion behaved similarly to those who did not have 17p deletion. Similarly, for idelalisib plus rituximab, here both patients with 17p deletion and p53 mutation were studied, and again there was no difference between those who had aberrations as compared to those who didn't. The problem is that when the follow-up was longer, so now we are around 3 years, then the patient with 17p deletion started relapsing earlier, and this is now confirmed in many studies. We do know that the patient with the p53 aberration respond as well as all the other patients, but then the follow-up, the outcome is, the PFS is shorter than other patients. Still, it is a PFS that we never saw before with any other drug, so we are happy with that, but the problem is not solved. It's somehow postponed, so now we are, as I always say to my patients, we are gaining time so that maybe other drugs can be developed in order to help them. Is it 17p deletions or p53 mutations? Yes, it is indeed. That's still the reason. There was the idea initially that complex karyotype could be the reason why these patients were relapsing earlier. The problem is that the 17p deletion is always present in this complex karyotype, and it is much stronger. The association with the 17p deletion and probably with p53 mutation as well is stronger than the complex karyotype. Anyhow, the ERIC again is starting a project that thanks to Arnon Kater, that wants to really understand if and how the complex karyotype can affect the outcome of a patient treated with ibrutinib. So as mentioned by Steve, now what we are talking about patients who relapsed, but not only relapsed, patients who have been over-treated. So we are talking about patients with a median number of treatment of 3 in the different studies, patients who have received up to 15 different treatments. So this is not CLL anymore. It's something that we hematologists created with all the chemotherapy that we gave. So here I show you the curve of the patient treatment naive patient. This is not the RESONATE-2 study, it's a phase 2 study where Steve was the first author. And definitely the curve is looking definitely better. These are all patients. Among these, there are 17p deleted patients, not a lot, but still they are there. So maybe if we start treating earlier these patients, and probably also the role of 17p deletion, p53 mutation will be different. We don't know, we will see, but there is hope at the end of the tunnel. And the same thing appears to be true for patients treated with idelalisib plus rituximab, though we know the problems of treating this patient in first line with this combination. We can discuss later. But still, in terms of response, again, among these patients, there are 17p deleted patients. The curve looks quite nice and promising. Having said that, we have another problem, which is how many patients are we actually detecting, for example, for the p53 mutation. So when we use a Sanger sequencing, we detect a portion of these patients, but then there are patients who have very minor clones, subclonal clones, that can be detected only by next generation sequencing. And this is a work by Davide Rossi and Gianluca Gaidano in Italy. And indeed, 1/3 of patients who have an aberration in p53 gene can be detected only by NGS. And the interesting point is that even those patients who have only subclonal presence of p53 mutation, so a minor portion of the whole population, so maybe even 1% or less than 1%, still, when the patient progress and when the patient need treatment, then they will have a dismal prognosis, as well as patients with a clonal p53 mutation. Indeed, if you treat them with, for example, FCR, if the clone is small, the one that relapses is a clone carrying this mutation. So somehow we are selecting out this population by using the chemotherapy. And just to make the point clear, the fact that one is carrying a small subclone of p53 mutated cells does not mean that this patient will have a dismal prognosis. So if there is a small clone and it is left untouched without chemotherapy, if the patient is not needing therapy, is not progressing, then the clone will remain there. So somehow the clone is under control. While instead, if the patient is progressing and then we use the chemotherapy, then we select out the clone. So now, again, maybe we have some hope in the future for a BT199. Again, as we know, we will discuss much more later. The BCL2 inhibitor is also providing very nice responses with complete remissions and even MRD negativity in patients with 17p deletion. So around 80% of the patients do respond, as well as all the other patients, including also fludarabine refractory. But again, we don't have such a long follow-up, so we don't know how this response will be maintained with time. But again, this is definitely promising, because here we get even complete remission, MRD negative complete remission. So I just conclude, I just remind you that indeed in Europe, and these are the new ESMO guidelines that we published together with Barbara and other colleagues. And so now in early stage, if the patient have 17p deletion or p53 mutation, they go straight to be treated, if needing treatment, of course, with BCR inhibitors, both regardless the fitness status. And in the relapse setting, the early relapse, which identify the patient with high risk, they also should go immediately, or whenever they need treatment, to be treated with BCR inhibitors. And also the late relapse, they should be screened for the presence of 17p deletion or p53 mutation, and then they should be treated with the BCR inhibitor, leaving then a very small limited portion of patients to be treated with chemotherapy. So just to enter the discussion of the next talks. Thank you very much for your attention.
Yeah, Wyndham. Maybe, Paolo, you can comment on what do we know about why the patients with 17p are failing. Obviously, mutations within the binding site only gives us a very relatively small number. One thing I've noticed is that the dose you are using in CLL 420 is lower than what we use in large cell. I know that Pharmacyclics has taken the dose up higher And then, of course, we've recently seen the New England Journal paper with the Acerta compound, where they're giving twice daily dosing, and they're saying that they're getting more continuous inhibition of Bruton tyrosine kinase. And so I'm just kind of wanting to get your thoughts around those various points.
Yeah, the pharmacokinetic pharmacodynamic point is always good, but I don't think it's really the solution. Of course, it is true with the Acerta compounds, there is much more compound sticking to the binding site. But again, the cases who relapse because of the mutation in the binding site are a minority. Of course, they were found. It's very nice because it's biologically meaningful, but clinically it's probably not so relevant in the end in terms of numbers. And it was interesting, there was a study at ASH showing that probably these mutations in the binding site is much more frequent than we expect, and then it does not correlate really with the resistance, and it may be present only in a minority of the population. So there is something else. It is true, again, we can go back to what Steve mentioned and what I showed you before. We are talking about a population that is 17p deleted. There is the complex karyotype. There are so many other aberrations that we don't really know what's happening. Of course, the cell is finding alternative pathway to survive, which is expected. That's why the combination therapy, and we should discuss that, will be probably the future. But again, the feeling is, probably also with the data that will be shown later, the feeling is that if you start on a naive, the earlier you start on a naive CLL population, then probably the better is the action of this drug, because in here, I have to say that I am a little bit biased. We do strongly believe that the disease, rather than being a genetic disease, is a microenvironmental driven disease. So there is where the BCR, the antigen stimulation, is relevant. If we hit the cells with chemotherapy, then we make it become a genetic disorder somehow, or a more genetic disorder. So if we hit it earlier, then probably the role of the BCR and the pathways is key. And so we could maintain the response much, much longer without probably so much resistance.
I mean, can we, because I think, can we say that in an ideal world where the new drugs were widely available, then it becomes imperative that at the time of treatment, patients are tested first by FISH. And if they're positive for 17p, they would go on the new drugs. If possible, they should be retested at relapse. So I think this is a major effort that should be done everywhere to try and offer this to patients now that the drugs are becoming available. Then there's an issue, what if a patient is negative by FISH? I mean, then we should do sequencing. I think this is very clear. I mean, again, in an ideal world. So then a network of few laboratories that can offer this facility, I think, should be a major aim within regions. So I'm not saying even institutes, I'm saying regions. Then there's a question you brought up at the end from the Italian study that we conducted. I mean, if this was retrospective, obviously, if we confirm this prospectively, as it might be, that the subclone is equally important, then I wonder whether we should be doing Sanger or whether we should go directly to next generation. That, I think, is still a question mark, but that, I think, is something on the table. If you have to set up a technique, this is the question. Should we go for conventional Sanger or should we think of doing next generation? Because the data are quite strong, that you have this minute subclone, this comes up over time. Yeah. Where there's a selective pressure of previous treatment, that could be, but we have to, so that I think that is the next challenge. So
that's a very correct question, and there will be a commentary in Hematologica in the next weeks, again by Eric, where we do make that point. So at this moment, NGS is a little bit too premature because it's not really validated. So Eric is again making an effort to create standards for NGS. But if I have to be honest, in probably 1-2 years will become the standard. So as soon as it is validated and will become available everywhere, then every patient probably will need to be tested by NGS. And also in a couple of years, we will have prospective data in the different trials so that we will be sure also on the clinical value. So as we are also going to talk about the MRD, probably in the next 18-24 months, there will be a shift from the traditional technology to NGS.
Because, I mean, this is, I think it's a key point, because we might be treating wrongly patients. I mean, that is a reality. So that's something I think practically extremely important. Any more comments? Yes.
My questions.
Sorry.
Start by the fish or start by the sequencing?
That's a very good question, regardless the resources, because even if they are unlimited, one should think and do the right thing. So also in Italy, what we always suggest is to start with fish.
Yeah.
If the patient is positive, you don't need to go and search for a p53 mutation. If he is negative, then you move to Sanger sequence.
And which exons do you sequence?
Say again?
Which exons? Do you do the whole sequence?
No, 2 to 9.
2 to 9.
2 to 10 even. So again, the ERIC, if you go on the ERIC website, there are all the, there is the manual, the guidelines, the recommendations, and there are different levels of proficiency. So we accept 2 to 9, the best would be 2 to 10. Excellent, but you can go through, you can become, if there is a lab in your institution, you can become certified by ERIC. We can discuss and see how to set up the best system. So please, if anyone wants to make some advertisement, if you want to go to the ERIC website, become a member, it's free, and then we can also discuss about the p53. What I wanted to say is, we were discussing about p53 mutation. Yeah, don't remember.
I think it's yeah. Okay. Yes.
I have a question regarding.
No, sorry, I just complete. Remember, that's the ideal world: fish first, p53 later. In some cases, it happens in real life. Is that to have the result from the fish, it takes up to 4 weeks, which is a nonsense because you need maximum a week. But then the lab could postpone it. Then your patient is progressing, you feel stressed, you're already late because they made a late diagnosis. I don't know. And so in that case, you can do it at the same time. Because it is true that the 2 tests, it can take up to 2 months to have the diagnosis. And maybe in some cases, you might feel that you are a little bit wasting time. That's the only thing. Sorry.
No, regarding this, so if we don't do sequencing, what percentage of patients are we missing to diagnose?
1 to 1, I would say, or maybe 1.5 to 1, yes. So the p53 mutations are 5% diagnosis, 5%, and diagnosis at the time of treatment. The 17p deletion is 7%, probably.
And can the mutational stage of the IGVH help us decide which patients need to go onto sequencing?
No, definitely, definitely not, because you might. It is true that more unmutated cases might have a p53 aberration, but still the patients with mutated immunoglobulin who have a p53 and they progress, they will do as bad as all the others. What is true is that patients at diagnosis, so you should not do that, but a patient at diagnosis with p53 mutation, if they have mutated immunoglobulin genes, it's very likely that they will not progress. But if they do progress, then the p53 mutation will have a role somehow, and they will have a dismal prognosis.
You know, overall the numbers are not that small, because if you put together fish, conventional sequencing, and minute subclone at the time of first-line treatment, is about 15% of cases. Yeah. So it's not that small. In a cost-saving issue, the question could be, should we do ZAP, CD, whatever, 38, 49? That is the question. I mean, we probably would say, to be practical, that they don't indicate anything, really. I mean, that's what we say. We do fish and sequencing. We do the immunoglobulin status, because that can be important, and that never changes. So at least you do it once, and that's it.
Yeah. Also for the immunoglobulin, sorry, just to comment, it is true. that it might become relevant in the future because of the SCR data that have been presented already.
We will
so
show
that-
them later too.
Yeah, okay.
Yeah.
So the longer follow-up show that mutated cases behave better, but we will discuss later. Yes, no, there was a colleague there.
Thank you. I think you use panel for a fish panel for all your.
No,
or
actually,
only-
no. What we suggest to be economically wise, do only the 17p. If you have 1 penny, invest in 17p. All the rest is just useless.
And I imagine that you perform cytogenetics as well when
No,
the sample
we don't do
arrives.
that. We don't do that. We are now discussing, there is this ongoing study within ERIC for doing traditional cytogenetics to check for the complex karyotype, because we don't have data about complex karyotype. And so that's something, but I would say that it's experimental. So again, if you have 1 penny, do the 17p and p53 mutation. All the rest is very questionable. You don't know really how to use that piece of information to change, to manage your patient.
Just to double check, included the complex karyotype?
No, we don't.
Yes, but you don't consider this, you consider this similar to the other genetic aberrations, not so important as
The
70p
published data suggests that having a complex karyotype is relevant. We don't really know how this is different from having the 17p deletion or the p53 mutation. So the data are not complete. So the data that are showing the complex karyotype as a role, they don't screen for p53 mutations, but only for the fish abnormalities. So the data is not complete there, and at the moment there is no recommendation to use complex karyotype to manage your patient. Studies are needed.
Still considered research, not
Yeah, it's
clinical.
research. So if you do that and collect the data, please share with the community. We can pull them together, but at the moment it's not.
So I should probably know this, but my focus is usually large cell. For the randomized studies that have looked at ibrutinib in patients up front that have 17p, was the control group, when they progress, mandated to receive ibrutinib at that time?
There is no such study.
Well, no, there are randomized studies that
Yeah.
showed that patients up front who had 17p, if they got ibrutinib, they had lower survival.
There is,
That
but
was
there is
a
no, there is
subset.
there
That
is no
was-
such study, and
No.
indeed the AMA and also the FDA approved for the first line use without any data.
No, I thought there was I thought there was
No,
an
the
upfront
only randomized
study.
is the Resonate
No.
2, the Resonate 2,
No.
but there is no 17p. The 17p deleted patients were not included.
Oh, I thought that was a subset.
No, all the others
analysis.
are phase 2
Yeah.
study.
Okay.
So
Well-
even there is a study with the 17p, it's called Resonate 17,
Right.
which is enrolling only 17p deleted patient, not p53 mutated patient, but it's a phase 2. It's a 1 arm.
So this raises the question
Yeah.
of whether or not you have to treat these people up front, because you need to mandate the control group gets ibrutinib at the time they grow.
Absolutely.
And
You're perfectly
so
right. There is no data. It's
there's
amazing.
no data
There
that
is
we
no
need to
data.
use this up front, because that trial's hasn't been done.
Absolutely.
But
No,
Paolo,
there is
data.
none-
There is data.
there
from,
is a study
Okay,
ongoing.
wait.
But there is data from NIH from your colleague Adrian Wiesner.
Adrian, yes.
That's
Yes.
phase 2.
Patients.
That's
It's a
not
phase
a
2 too as well.
randomized study.
I agree. But
this-
there is a study treating patients up front with single agent ibrutinib in
Exact-
17p patients.
Right.
And he's published that.
No, but there is also the Resonate 17.
Correct.
So no problem for that. But the problem is what he's saying
But in
is that we don't
treatment
have the proof, and we don't have a randomized study, so we
No.
don't know if they are doing better or not.
But isn't not a study ongoing in Germany?
Yeah,
First line, they are randomized at the high risk ibrutinib ES versus observation. I think that-
okay, that's another
that's
thing.
ongoing.
Patient not needing treatment.
Yes, exactly, but that's the
So-
key point.
No, but
Patient-
then probably there are no 17p deleted patients.
Well, maybe there are. I mean,
Maybe.
17p is not an indication for treatment per se, so some
Yeah.
17p could be included there.
But I
Maybe-
guess the point is, we're talking about as though it is certain that upfront 17p or perhaps P53 mutations mandates ibrutinib up front. And what I'm saying is there's not a shred of evidence that's true, because it may be that you can use it at the time that it shows up later on.
Yeah.
That's all I'm saying.
So,
We all say that we need to treat only when the disease progresses. When upfront is
That's the question.
Yeah.
Yeah.
So I
No, that's
think
all
when-
research.
I think, Wyndham, your question is a good one. I think that the FDA and EMEA made the decision for the recommendation based upon the fact that FCR's progression-free survival for 17p is around 10 months.
Yeah.
The progression-free survival in a relapse setting for ibrutinib is 28 to 30 months for 17p. And I think, second of all, Adrian's data shows that the median PFS for those treatment-naive 17p patients hasn't been reached at 3 years. So that the data really lines up that using it first does work better. I mean, the median survival for a 17p patient first line is, what, 2.5, 3 years. So the PFS for ibrutinib single agent front line is better than the survival. So I think the data is there. I think it would be hard for a company now to go do a trial in a randomized setting to do that.
Well, I just want to go into history. When rituximab came along, there were numbers of randomized studies with rituximab-based regimens showing that if you use it up front versus a chemo without it, the survival was improved. But these were trials coming out of Europe where rituximab was not approved and was only available in patients on clinical trials. So the control arm, many of them never got it. Okay, and while U.S. trials never showed that early versus late really made a difference. So although all of that may be true, Mark, I just think that it's not always certain that early use of these drugs necessarily will be different than using them later on. And again, I'm only getting at that because there's a huge cost, and it's difficult to be screening everybody for 17p and up front.
For
That's all I'm
for your information, but that's probably again not the perfect word, there is an ongoing study comparing ibrutinib in first line with 17p deletion versus acalabrutinib, the Acerta compound. So there we will have at least that piece of information, and of course we will see also the PFS curve, generally speaking. So that might help. But I understand your point. It is true that probably will be like study, real life study. So we will see by treating the patient if this is better or not. And the named patient program that Robin was mentioning in Italy will also provide, out of 400 patients, probably a bunch will have 17p deletion.
And one of the things, and your example is, from the solid tumor world, is like the EGFR mutations in lung cancer, where the targeted therapies, EGFR inhibitors, have tremendous improvements in PFS. The overall survival, which means giving them first or second, is actually not that much. Though with time, as we're getting better and the agents are there, it does look like there's a survival advantage overall coming up because of the fact that some patients who get the subtherapy never get subsequent therapy. They just can't because they decline. So I think your point is exactly, you got to get these drugs sometime in their care, but there may be an advantage up front, because of you get 100% of the patients. The question is, though, it still brings in costs and screening and all. But that's it. So I think that's what it is. So I think it's a good point, and it's a lot like the EGFR setting in solid tumors.